Hello, everyone, and welcome to our Essential Tremor Virtual Education Forum. My name is Patrick McCartney, and I'm the Executive Director of the International Essential Tremor Foundation. Today, we're going to be hearing from Dr. Arif Dalvi, who will be discussing the differences between essential tremor and Parkinson's disease. Before we get started, I want to thank our corporate partners, Medtronic, Sage Therapeutics, Jazz Pharmaceuticals, Cala Health, Boston Scientific, and Praxis Precision Medicines for their support. Their support allows us to provide these webinars, our podcast series, and our in-person ET education forums. So before we get started, I want to introduce our speaker, Dr. Arif Dalvi. Dr. Dalvi is the Director of the Comprehensive Movement Disorders Program at Palm Beach Neuroscience Institute, Director of the St. Mary's Medical Center Memory Disorders Center, and Physician Chief of the Movement Disorder Program at Delray Medical Center, along with being a member of the IETF Medical Advisory Board. He is fellowship trained in Parkinson's disease from Columbia University and was director of the Neurology Residency Program at the University of Chicago Pritzker School of Medicine. He's conducted research for over 20 years on the medical and surgical treatment of Parkinson's disease, Alzheimer's, dystonia, and essential tremor, and is currently involved with applications of focused ultrasound in Parkinson's disease and other neurological conditions. So Dr. Dalvi, welcome. Thank you for joining us today.
Thank you, Patrick, for the very kind introduction. And I will share my slides and we can get started. So the topic of today is essential tremor versus Parkinson's disease. Almost every patient that I see with essential tremor has a concern, could this be Parkinson's disease? And almost every patient with Parkinson's disease says, are you sure I have Parkinson's disease? Why is it not just essential tremor? So in order to address that, I thought I will go over some of the theoretical background in terms of how neurologists think and evaluate these conditions. And towards the end, if you stick around, we will hopefully have some video images of these different types of tremor that we see in our clinical practice. So firstly, let's come to what is essential about essential tremor. In common English, when you say the word essential, it means you need something. Nobody needs a tremor in their life. So we got to dig into history to understand where this term came from. Pietro Burresi, who was professor of medicine in Siena, Italy, which is a really pretty little town in Italy, he described this condition called tremore simplici essenziale. Pardon my Italian, which is not so good, but he was the person who came up with the term simple essential tremor in around 1874. The term in medicine, it refers to when you say essential, it means an isolated syndrome. So this is an isolated tremor. There are no associated symptoms. Another way to describe it is it's monosymptomatic. It's idiopathic without a specific cause. And some of the history was described by Lewis et al. In 2008 that I would highly recommend for somebody wanting to dig deeper into this terminology. There are other descriptions of essential tremor. Benign tremor is a term often used, but I don't think it is quite appropriate to use the term benign tremor because, yes, there are many people with a relatively mild essential tremor, but on the other hand, there are equally as many for whom essential tremor is quite disabling in terms of eating, drinking, other day-to-day activities. Even socially, it can be disabling. Familial tremor is also used because much more commonly than in Parkinson's disease, we do see a familial inheritance in many patients. The ICD-10 code for essential tremor is G25.0. We have talked about essential tremor as being isolated or monosymptomatic. Question is, can essential tremor have associated symptoms? And certainly there are some presentations where you can see essential tremor with associated symptoms. So, for example, there's a genetic condition called Fragile X-associated tremor ataxia syndrome. And what happens in this is there's an expansion of what are called as the CGG repeats in the Fragile X gene, also called as FMR1 in the premutation range. Now, what does that mean? If you have less than 55 of these repeats, this is normal. If you have over 200, then you present with a condition that involves learning disability, other major cognitive issues right away in childhood. But if you have that in-between number of repeats, 55 to 200, then you will see essential tremor-like syndrome with a postural tremor, typically some ataxia, unsteady gait, which is called as a cerebellar gait ataxia, some frontal executive dysfunction, and occasionally Parkinsonian signs such as bradykinesia and rest tremor. This usually occurs in men because it is X-linked. Very rarely it can occur in women also. How common is essential tremor? As a comparison, there's about 7 to 10 million people in the United States with essential tremor compared with about 1 million with Parkinson's disease. When you do a community study, for example, the Washington Heights Inwood study was published in 1996, 108 out of 1,056, that's approximately 10% of individuals over 65 had shaking. Of these, 8.3% had rest tremor, 17.6% had action tremor, and the prevalence of Parkinson's disease was estimated at 3.2% and essential tremor about 10.2%. How do we make a diagnosis of essential tremor? The clinical criteria for essential tremor have continued to evolve, and the complicating factor is we don't have a specific biomarker for essential tremor. There's no blood test or imaging study that can diagnose essential tremor with a high level of certainty. We do order a brain MRI or a CT scan as part of the initial workup, but this is more to rule out other causes. For example, strokes in the brain or multiple sclerosis can sometimes present with tremor, for which a brain MRI can be very helpful. DAT scan imaging, which is dopamine transporter scan imaging, we'll talk about later on. This can be helpful as it is abnormal in Parkinson's disease or Parkinsonism, but it's normal in essential tremor. However, for the most part, the diagnosis of essential tremor remains clinical. The neurologist or physician will take a history and physical, and based on these findings, will evaluate a person as having essential tremor. Especially for research purposes, we do use certain criteria in order to classify essential tremor into definite, probable, or possible. The diagnosis clinically depends on the phenomenology of the tremor. How does the tremor present itself? And we broadly describe tremor in two types. Rest tremor is where the body part is supported and not activated. So, for example, if the patient is resting their hands in their lap, the body part is supported and is not activated. So we say if we see a tremor in that position, we would call it a rest tremor. An action tremor occurs when there is voluntary contraction of the muscles, and this can take various forms. A postural tremor, maintaining position against gravity, for example, with the hands held out. A kinetic tremor during movement or at target, in which case it's also called an intention tremor. So, for example, if the patient is performing a finger-to-nose movement, and just as the finger is about to reach the nose, a tremor shows up, we would call it an intention tremor. Task-specific tremor only occurs during a task such as writing, and we'll talk about dystonic tremor later as well. Isometric tremor occurs during muscle contraction without a change in position. So we try to observe for these types of tremors, and based on what we see, we try to categorize the tremor in terms of the specific diagnosis. This slide is taken from one of my chapters on the phenomenology of tremor. We can go through this in a fair amount of detail because I think it is helpful in terms of classifying tremors overall. Firstly, you have the rest tremor, often called a pill-rolling tremor, seen in Parkinson's disease, other forms of Parkinsonism, sometimes in Wilson's disease. This is usually associated with other symptoms. So slowness of movement called bradykinesia, muscle stiffness or rigidity, stoop posture, shuffling or freezing gait can often accompany rest tremor. Postural tremor occurs when the hands are outstretched or performing actions such as pouring from a cup. Essential tremor is the most common presentation. We've talked about Fragile X tremor ataxia syndrome as well. Usually this tends to be a monosymptomatic type of tremor. Kinetic tremor can occur during any voluntary movement, and this can often be seen in multiple sclerosis or cerebellar tremor. There's a component of ataxia associated with this, which is difficulty in pinpointing the fingers or the body part to a particular area. Task-specific tremor only occurs during activity. So, for example, writer's cramp or occupational tremor, and this may be associated with dystonic posturing. There's one relatively rare type of tremor called Holmes tremor or rubral tremor after Sir Gordon Holmes, who described the tremor. Initially, it was thought to occur with lesions of a part of the brain called as the red nucleus. But with MRI imaging, we find that other areas such as the thalamus or midbrain lesions can be causing this tremor as well. And this tends to have a combination of rest, postural, and kinetic tremors as well. A common associated finding might be cranial nerve findings because the midbrain is the area that has the nerves that control the eyeball movements. So coming to the basic question, essential tremor, Parkinson's disease. Let's go through some of the features. So essential tremor, age at onset tends to be bimodal, typically in the elderly, but we also have people who present in childhood or in their teenage years with tremor. Parkinson's, for the most part, a typical age of onset is somewhere between 55 to 65, but sometimes you can have young onset Parkinson's disease as well. Clinical course in essential tremor tends to be relatively slow. In Parkinson's, it's more rapid and disabling, especially on account of the associated symptoms. The type of tremor tends to be postural and kinetic in essential tremor, and it can be a rest tremor. But sometimes there is a type of tremor called re-emergent tremor, where the patient has a rest tremor. When they hold their hands up, the tremor disappears. But if you wait for half a minute or a minute, they now seem to have a postural tremor. This is called a re-emergent tremor. I think I should be able to show you a video in a bit of this type of tremor. Frequency can be measured. Essential tremor, 4 to 10 hertz. Parkinson's tends to be a slower tremor, 3 to 5 hertz. And again, essential tremor is monosymptomatic. Parkinson's, bradykinesia, rigidity, and gait disorder help define Parkinson's. In fact, about 20 to 30% of patients with Parkinson's never ever have tremors. So the defining symptom really is the slowness of movement or bradykinesia. Important to remember that you can have essential tremor and Parkinson's disease in combination. About 6 to 10% of patients with long-standing essential tremor may develop superimposed Parkinsonism. Essential tremor with Parkinsonism, we've already said, can be seen in FXTAS. In some families, essential tremor and Parkinson's disease may be genetically linked, and some family members may present with essential tremor and some with Parkinson's disease. And in fact, patients with Parkinson's disease are 3 to 13 times more likely to have a diagnosis of essential tremor than patients with atypical Parkinsonism. We talked about dystonic tremor. This is more likely to be task-specific or vary with position than essential tremor. The prototypical dystonic tremor is writer's cramp. These people might not have a rest tremor. They might not have a tremor with their hands outstretched, but give them a pen and ask them to sign their name, and they will have a significant tremor develop in that hand. Patients with head tremor may have a mix of essential tremor and cervical dystonia as well. So these dystonic tremors usually vary with position. In certain positions, there may be a null point where the tremor goes away, and in other positions, the tremor can be significantly exacerbated. There's also mention in the literature of essential tremor plus syndromes. We have sort of hung our hats on essential tremor being monosymptomatic, but there is a heterogeneity of essential tremor that is increasingly recognized. Patients with older onset may progress more rapidly. Patients without head tremor may progress more rapidly. Patients with jaw tremor are more likely to convert to Parkinson's disease. Let's come to the diagnosis of essential tremor. As I've said, the diagnosis is clinical, both for essential tremor as well as Parkinson's disease. But if there's diagnostic confusion, DAT scan imaging can be useful. DAT scan stands for dopamine transporter imaging. This uses radiolabeled ioflupane to mark the dopamine transporter molecules, which can then be imaged with a SPECT scan. In essential tremor, there's no loss of dopaminergic terminals. So the DAT scan reveals a comma shape that you can see in the slide. In Parkinson's or Parkinsonism, there is loss of dopaminergic terminals. So therefore, there will be a period-shaped appearance, and oftentimes you will see an asymmetry. So in the slide, for example, you can see towards the left-hand side, there is more signal. Towards the right-hand side, there is less signal, which would indicate an asymmetric tremor in this patient. Let's go over some videos of patients with these typical types of tremors. So we have sort of a visual representation for what these are like. The first case is that of a typical Parkinson's disease tremor. This is a 74-year-old man who has rest tremors predominantly on the left side. Additionally, he has left-sided bradykinesia and rigidity. Over the past year, his gait and balance have declined. He responded to carbidopa-levodopa initially, which is the main treatment for Parkinson's disease. But then the left-sided tremors have become intractable, so he was referred to us for surgical options. We attempted to add dopamine agonists and trihexyphenidyl to the carbidopa-levodopa regimen, but this was unsuccessful, so he's considering surgical options.
The tremor wakes me up a little bit at night. I have to put it under the pillow or under part of my body part to stop it. It's mostly in the left hand. It bothers me when I'm having dinner, particularly when I'm out with other guests. It's a little embarrassing, so I try to eat with my right hand or try to pick food that I can spear with a fork. Otherwise, if I have like a chopped salad or something, I need a spoon to help me out.
How's your handwriting?
Erratic.
Is it bigger, smaller than it used to be?
Smaller.
How are you doing with walking and balance?
I can walk pretty well. I try to walk when I play golf. The balance can be an issue. Like if I step out of the golf course, I feel like I might fall. But I haven't fallen. This has been bothering me.
Do you ever shuffle or take small steps when you walk?
I do.
You do. Is there one foot dragging or any such thing?
I feel like my right foot plops into there.
All right. And let's see you hold your hands straight out like this, straight in front of you. Yeah. And bring your hands in like this. Reach out, touch your nose back and forth. Notice there's minimal postural tremor. And you can see, especially in the left hand, within a second or two, there's a rest tremor developing. And let's see, work your right leg up and down. And your left leg. You try the ankle like this, just with the right first. As quick as you can do it. Move the left. And let's see you cross your arms in front of you. And let's see you stand up if you can. All right, very good. You can see the prominent left hand rest tremor and a little slow gait. So that was your typical Parkinson's disease presentation. The next case has tremor-dominant Parkinson's disease. This is a condition where patients present with Parkinsonian signs, including rest tremor, slow gait, or they may have bradykinesia in terms of slow movements. But it tends to be mainly a tremor. They don't tend to have significant issues with balance, even though they might have had the tremor for a significant period of time. This is very relevant in light of the new treatments that are available with focused ultrasound, because this has been approved not just for essential tremor, but also for tremor-dominant Parkinson's disease. So this is a 68-year-old man with intractable tremor on his right side. He does not have any issues with gait and balance, although as you will see on the video, his arm swing is diminished. Levodopa treatment has not been effective in controlling the tremor. We have also tried essential tremor treatments with propranolol and primidone, which did not control the tremor. So he was actually referred for focused ultrasound, being tremor-dominant Parkinson's disease.
I have a shake in my right hand. It has about a 10-second delay. And once it starts, I can stop it. And then wait another 10 seconds and it'll start again.
What kind of day-to-day activities are affected?
Typically it's brushing my teeth. I have a little bit of issue going sideways or something. When I get in and start brushing my teeth, I can't really brush my teeth the way I like. I have to use my left hand.
Sure.
I don't have a problem eating, except if I'm slow. If there's a 10-second delay in the shake, if I eat fast, I'm fine.
Got it.
Other than that, I don't have any other issues except being embarrassed if I'm with a group. Obviously I keep my hands under the table.
Understand. And in terms of walking, have you noticed any change?
No change. I do walk about 2 miles every other day.
Right.
No issues.
How about your arm swing? Has that changed a bit?
No, I have one that swings and the other one doesn't shoot. The right hand doesn't swing much at all.
Got it. How's your handwriting? Bigger, smaller, about the same?
About the same, but I can write one sentence and then the second sentence I have to wait to write the second sentence because otherwise it's going to go all over the place.
Got it. So let's see you bring your hands straight ahead in front of you. There you go. And your tremor actually stops and then restarts. Rest it back down again. Rest it back down in your lap. So you saw a rest tremor and a re-emergent tremor when he held his hands out. Let's just see what's happening. Now bring it straight ahead in front of you again. Both hands. So no tremor, and then it starts in the right hand. Bring your hands in like this. Yeah, stops for a bit and then restarts. Try this with the right hand. With the left hand. Now with the right leg, go up and down. The left leg, please. Good. And try at the ankle. And with the left side.
We'll have a problem with that knee replacement.
Got it. And then let's see if we can have you cross your arms in front of you and try to stand up with your arms crossed. All right, you did that pretty easily. And come on back. Excellent, thank you. Just try to write something.
Oh, when you're ready. Are you ready?
Yeah.
I used to have good handwriting.
And try a spiral, going a spiral.
Okay.
Inside out. Try with the left hand drawing a spiral. So again, this is someone where tremor is disabling in terms of day-to-day activities, eating, drinking, handwriting, and as he said, even socially, and multiple medications have been tried without success, which is why he was referred for focused ultrasound treatment. The next case is another issue that we see from time to time. This is somebody who's had a 30-year history of postural tremor consistent with essential tremor. And for a number of decades, the tremors were well controlled with long-acting propranolol, but recently the patient has experienced a worsening of tremors over the last 2 years. In addition, he has developed difficulty with gait and hypophonia, and in fact, even has had occasional falls. So this raises suspicion that there is superimposed Parkinson's disease over and above the essential tremor, which occurs in about 6 to 10% of ET patients. Okay, and how many years have you had tremor for? And how is the tremor affecting your day-to-day life?
Makes it a little difficult, like opening pages in the book.
Has it affected your handwriting?
Yes,
Yeah, how is your handwriting different from, say, 2 years ago?
2 years ago it was better.
In what way?
Uh,
In what way?
Better that I could make my day much better than now. Now it's like way
Was it bigger, smaller, about the same in size?
about the same.
And we're seeing a little tremor in your hands, but let's see you hold your hands straight ahead in front of you. That brings out the tremor a bit more. Can you bring them in like this, in towards you? And reach straight ahead in front and then back to your nose about 3 or 4 times. Same on the other side. So he has the postural
right
tremor
hand,
and intention tremor, but also a little bit of rest tremor and some slowing of movements. With your right leg, go like this. And with your left. So a little slower on that side, and over here we're seeing a little rest tremor in your left side as well. And let's see you cross your arms and stand up and just stand next to your chair. You need to use a cane. Oh, that's okay. You can push yourself up. That's fine. All right. And come on back, please. So you can see a little stoop posture, a little unsteady gait. You can see the rest tremor. Excellent. Thank you. So the treatment option for this patient was actually starting carbidopa-levodopa, which did help the rest tremor and help the gait and balance. He had originally been referred for surgical treatment for the tremor, but due to the presence of bradykinesia, gait disorder, we did not recommend surgery, but rather went with the addition of carbidopa-levodopa instead. This is now essential tremor patient who's actually undergone focused ultrasound surgery. This is a 67-year-old man with postural tremor in both hands, right hand dominant. He was on propranolol, primidone, gabapentin, all of which failed to control his tremor. We did try the Calotrio device and he did not get adequate relief. Again, significant impact on day-to-day activities in the year leading to surgery. Again, some social withdrawal due to embarrassment from the tremor. I have to thank my neurosurgeon colleague, Dr. Lloyd Zucker, who successfully treated this patient. And the other hand too. Keep them both up for a minute. And bring them in towards your chest like this. Reach out, touch your nose back and forth. 4 or 5 times. And the other side. Reach out, touch your nose. Beautiful. Right hand open and close. Left hand open and close. Bring them in like this, pointing towards each other, both sides. So we did a left thalamic lesion with focused ultrasound to help his right side. The other side. And you can see how steady that right hand is. Right hand open and close. Right hand open and close. Just the right hand. And the left hand. The left hand continues to shake because it is untreated. And this is him 4 years after the surgery.
Which one?
Both of them straight ahead. His left hand tremor actually looks a little worse, which is expected with progression. But you can see the right hand continues to remain very steady even 4 years after the initial focused ultrasound procedure. Reach out, touch your nose back and forth. Same the other side. So I hope this was useful information, especially in terms of the videos demonstrating the different types of tremors. If you would like more information, please contact me at Palm Beach Neuroscience Institute, pbni.com, but I will hand things over to Patrick now.
Thank you, Dr. Dalvi, for taking the time to speak with us today and share some great information on the differences between essential tremor and Parkinson's. We hope everyone found the presentation really helpful and maybe you learned something hopefully new today. If you have any questions regarding essential tremor, please visit the IETF website at essentialtremor.org, or you can call us toll free at 888-387-3667. And finally, if you are a donor to the IETF, we thank you for your support. And if you aren't currently a donor, we hope you'll consider a gift to help us continue the work we do, promoting ET awareness, education, support, and research. We're going to be hosting a variety of virtual ET education events in the upcoming months. So look for notices about these events in our Tremogram e-newsletter, on our social media channels, and our Tremor Talk magazine. So Dr. Dalvi, thank you again for joining us today, and we hope everyone has a great day.